Good afternoon, everybody. Thank you very much, Professor Cuijpers and Professor Araya, for accepting the invitation of the Millennium Institute for Research in Depression and Personality, MIDAP, to present and comment on this seminar entitled 5 Decades of Research on Psychological Interventions to Prevent and Treat Depression, Opportunities and Challenges. I also welcome those who have joined to listen to this conference. In the first part, Professor Pim Cuijpers will present and later Professor Ricargo Araya will comment on the presentation. Before starting, I would like to share with you some background information on Pim Cuijpers' outstanding career. Pim Cuijpers is Professor of Clinical Psychology at the Vrije Universiteit Amsterdam, the Netherlands, and director of the WHO Collaborating Centro for Research and Dissemination of Psychological Intervention in Amsterdam. He was involved in more than 75 randomized controlled trials and more than 300 meta-analyses on prevention and psychological treatments of common mental disorder across the lifespan. Much of his work is aimed at prevention of mental disorder, psychological treatments of depression and anxiety disorders, and digital intervention. He has also published on several other research topics, including global mental health and student mental health. Pim Cuijpers has published more than 1,250 peer-reviewed papers, chapters, reports, and professional publications, including more than 1,000 papers in international peer-reviewed scientific journals. He is on the Thomson Reuters Web of Science list of the highly cited researchers since the first edition of this list in 2014, and he recently received the 2024 APA Award for Distinguished Professional Contribution to Applied Research. It's an honor to present the conference of Professor Cuijpers. Now you can present Pim.
Thank you very much for the very kind introduction and for having me here today. And I'm very happy to talk today about our meta-analytic work, in which I have spent much of my time the last 20 years next to the other work that I've done. And yeah, so I'm happy to talk about meta-analysis on psychological treatments of depression. I'm now going to share my screen, and I hope it works. And I hope you can all see my presentation. What I will do in my presentation is I will first very briefly talk about the disease burden of depression. You all know that, so I will be very brief. Then I will talk about our approach to meta-analysis, which is different and a bit new compared to traditional meta-analysis. And that has resulted in a lot of knowledge about the effects of psychological treatments of depression. And that's, I want to summarize what we've learned about that in the meta-analytic research that we have done. And then I will focus on one specific question. I had to choose for the specific questions because we have focused on a lot of specific subjects. And I chose to focus on the question whether psychotherapy, pharmacotherapy have comparable effects, and what about combined treatment. And then I will finish with some conclusions about how we could improve the treatments we have for depression. First, the disease burden of depression, you know all that. It's a very common disorder. It's very expensive. Many people have it, not only in high-income countries, 80% live in low and middle-income countries. And if you want to know more about depression, you should read the report of the commission, the Lancet Commission, together with the World Psychiatric Association, the report on depression. It's called Time for United Action on Depression. That has everything you want to know about depression, all the recent knowledge. I was mostly involved in the writing of the treatment part, but it has everything about epidemiology, about causes, about genetics, etc., etc. So if you want to know something more about depression, you should read this report. But I take out one slide of that, which I find very illuminating, and that indicates the disease burden in terms of disability-adjusted life years across the lifespan caused by depression. And as you can, on the horizontal axis, you see age, and on the vertical axis, you see the disability-adjusted life years. And why I find this very illuminating, this slide, is for two reasons. First, it shows that depression, like all other mental disorders, is mostly a disorder of the adult age, and that's the working age. While heart disease, cancer, diabetes, these disorders, people get that when they get older. But mental disorders, like depression, are disorders of the working age. And that's why they are so expensive. And that's why the economic costs of depression, anxiety, and other common mental disorders are so staggeringly high. And that's for many politicians, that's a reason to think about the development of mental health care in countries where there's no infrastructure for mental health care, because it's also an investment in the economy of a country. In the UK, this was the reasoning why they started a large Araya program, where they invested lots of money in the development of mental health care for people with depression and anxiety. We did a study with Dan Chisholm of the WHO, where we calculated that for every dollar you invest in the development of mental health care in low and middle income countries, that the return on investments is $3 to $5. So for every dollar you invest, you get $3 to $5 back in terms of an economic investment. The other thing you see from this slide is that depression is mostly something of low and middle income countries. So the 20% of the people living in high income countries across the world, including Chile, if I understand it correctly, that's only a fraction of the small part of the people suffering from depression across the world. So I often say to people when I talk about this that there are more depressed people in China than the whole population of Spain together. And there are more depressed adolescents in India than the whole population of the Netherlands. So the numbers are staggering. But anyway, what is a problem of treatments is that they are effective. I will show that later to you, but the uptake is very low. That's 28% in high-income countries to 70% in low-income countries, but even lower in all kinds of high-risk groups, adolescents, young adults, older adults, minorities. But even in optimal conditions where we could reach everybody, where we could find all the people with a depressive disorder, and we would be able to give them an evidence-based treatment, everyone, then still only the disease burden would be reduced with about 33%. So 2/3 of the disease burden cannot be taken away by the current treatments we have. That's based on a somewhat older Australian study, but there's no reason to assume that it's not valid outside Australia and that things have changed very much. So yeah, what do we need? Well, we need basic research to understand what depression is. But if we really want to make a difference, we should talk about prevention, about simplifying treatments and increasing uptake, and to try to increase the effects of treatments. And that's what I'm going to talk about today. My other work has focused on the other two subjects, so I'm not going to talk about that today. So I want to talk about meta-analysis. That's the second part of what I want to talk about. Yeah, what we have done is we have usually what you do when you do a meta-analysis, you collect all the studies which compare psychotherapy with a control condition, or CBT compared to interpersonal psychotherapy for depression. You get all the studies and you do a meta-analysis, and that's it. What we do is we collect all the studies on psychotherapy, all the randomized trials on psychotherapy, regardless of the type of therapy, regardless of the age group, regardless of the target group, regardless of the comparator, whether that's a waiting list or another therapy or antidepressants or combined treatments. It doesn't matter if this study uses individual therapy, digital therapy, anything that examines a psychological treatment for depression in a randomized trial is included in our living systematic review. And that gives us, basically, that gives us the opportunity to summarize everything that can be known from randomized trials in our field about the effects of psychological treatments of depression. We do that for depression, but we also have a lot of other now what we call meta-analytic research domains on anxiety, on borderline, on PTSD, we're now working on to add eating disorders and bipolar disorders. So we're quickly extending this idea of meta-analytic research domains. And now I want to step away from, I just want to show you how our databases look like, because you can use it yourself. So you can run your own meta-analysis and you can look into all the data sets we have and just run your own meta-analysis. And I will, I hope you can see this. Okay, so this is the website of our project, and today we're talking about depression, and we will start exploring the website. You can go to the website yourself and do this right away or later. And you can, if you click on Start Exploring, you can choose mental health professionals, or you can choose for patients and other stakeholders. Let's do first the mental health professionals. So here you see all the data sets we have. And because we're now talking about psychotherapy for depression, I look at the largest one. So it takes a while because it really gets the data. So we have now 415 studies in this database. And when you click on Start Analyzing, you get into a new screen where you can see all the studies. You can download them with the effect sizes, with all the characteristics if you want. But you can also, I move this one to another place. You can also make a selection. So let's see, we are interested in perinatal depression, for example. And we want to see if group therapy works for perinatal depression. So we remove all the other data sets, that parts of the data. And then we select only studies on group therapy for perinatal depression. And if you then click on Update Table, here you get all the studies on group therapy for perinatal depression. And then if you click on the other button, run meta-analysis, you get a full meta-analysis. So here you see that the overall effect size is 0.81. The numbers needed to be treated is 3.6. Heterogeneity is very high. You can generate all kinds of plots, like a forest plot. Here you see it. You can look what happens when you exclude outliers. You can look at publication bias, risk of bias, and you can even do moderator analysis. So this is what you can do. You can go to the website and examine, does digital therapy work in college students? Does CBT work in older adults? All these kinds of questions. You can just go to the website, select the studies, and run a meta-analysis online with everything on it. Let's see. And I will briefly show you also what we have for patients. So for patients, nobody understands what effect sizes are. So we want to see, okay, we're focusing on depression, and we're looking for a specific type of treatment. So let's see, we take cognitive behavior therapy, which is by far the best studied. And patients can go there, select a target group, and what you get is this result. You can see that 40% of people who get CBT for depression in adults respond, which means 50% symptom reduction. And if you don't get that treatment, you get a 20% response. You get also all kinds of information about how trustworthy the results are, the sample sizes, the heterogeneity, but then in simpler terms, the study quality, etc. You can also create a report and download it. So this is what I wanted to show you, because this is there you can see basically what's in there, and you can. I will summarize now what we have learned from all this field and all the meta-analysis that we have published. But most of the information is just online, and you can go there yourself and run your own meta-analysis. Okay, so if we look at the fields of psychotherapy for depression, we have now more than 1,000 randomized trials. So that's a huge body of research, examining all kinds of types of therapies, comparing therapies with each other, with control groups, with pharmacotherapy, different formats, individual versus guided self-help, unguided self-help. So we have a lot of information, and about all these comparisons, we have done meta-analysis for most of these things. We have published now more than 100 over the last 15 years in which we developed this. We published about more than 100 meta-analysis. One of the recent ones was published in the American Psychologist last year. It's still an EPUB, so it's not in an issue yet, where we looked at these 5 decades of research, and we looked at the effect sizes, but also how has the field developed. And what you see, a few things, it's a lot of materials we got there, but what you see is that most studies were done until the mid-1990s in the US. Since 1990, there are more and more studies in Europe, and there are now more studies in Europe than in the US. But since 2000, there are also many trials being done in other countries. And for example, in the number of studies in East Asia is also increasing very rapidly, in which Ricargo is involved quite a lot. One thing that we also saw is that CBT is by far the best examined therapy, but it's also becoming more and more dominant. So here you see how it develops over time. And the red line is CBT. And you see that other types of therapy compared to CBT are less and less examined. So for example, interpersonal psychotherapy, which has the same effects, comparable effects as CBT, it's less and less examined when you compare it to CBT. And that's also true for problem solving, life review, behavioral activation, etc., etc. What is worse, here you use, I don't know if you can read all this, it's pretty small, but in summary, it also says that there is more and more research in adults and in people with general medical disorders, but other target groups are lagging behind. And there is significantly less research in children and adolescents than compared to adults. And that's worrying because, as I will show you later, the effects in children and adolescents are significantly smaller than in adults and in older adults. So it's worrying that there's less and less research in children and adolescents. For the other target groups, we know pretty well that the effects we find there are very comparable to what we find in adults in general. So we did a couple of years ago a large network meta-analysis in which we compared all the psychotherapies with at least 10 randomized trials with each other. And a network meta-analysis, and what you do in a network meta-analysis is basically a lot of pairwise meta-analysis at once. So in one conventional meta-analysis, you could examine CBT versus care as usual, and that would be one meta-analysis. But in a network meta-analysis, you have CBT versus care as usual, or waitlist, or CBT versus supportive therapy or behavioral activation. And so you do all these comparisons at once in one big analysis. And that has the advantage that you can use direct effects. So for example, CBT versus interpersonal psychotherapy, but also indirect effects. If you have trials comparing CBT with care as usual and trials comparing IPT with care as usual. So you put all this evidence together in one big analysis. And that's what we did with psychotherapies for depression. So we have more than 300 trials, 34,000 patients. We had cognitive behavioral therapy, interpersonal psychotherapy, brief psychodynamic therapy, problem solving, behavioral activation, life review, which is usually used in older adults. We clustered the third wave therapies into one category. We had non-directive counseling as one type of therapy. And we included all studies comparing these therapies with each other or comparing them with care as usual, waitlist, or pill placebo. What we found is effect sizes between 0.3 and 0.8 when you compare it to care as usual. And we found no significant differences between therapies, except for counseling, which was a little less effective, but that's probably an artifact. If you want to read that, we wrote a paper about that a couple of months ago in the Journal of Affective Disorders. We found the same thing in studies with low risk of bias, so the high quality studies, when we limited to studies with high quality, the results did not change. We also found significant effects of psychotherapies at 12-month follow-up. I will come back to that later when I compare it with antidepressants, because this is important. Therapy works not just at the short term, but also at the somewhat longer term. Well, recently, last year, we published a large paper in World Psychiatry on cognitive behavior therapy, very large meta-analysis for more than 400 trials, more than 50,000 patients. Basically, we found the same thing as what we found for other therapies. It is the best type of therapy, it's effective, but it's not more effective than other therapies. And effects are not declining over time, up to 12 months after treatment. But I will come back to these things later on because we have worked all these things out in more extensive therapies. As I said in the beginning, a problem of meta-analysis is that they're always reported in terms of effect sizes. So HSG or Cohen's d, which indicates the difference between the treatment and the control group after treatment in terms of standard deviation. So an effect size of 0.5 indicates that the treatment group and the control group differ 0.5 standard deviation after the treatment. But that's not very informative for patients. And for many clinicians, it's also very difficult to understand what it actually means. A patient just wants to know what's the chance of getting better when I get this treatment. So what we did is we looked at the absolute outcomes, response, remission, reliable change, and also deterioration. We used a statistical trick to do that. We had more than 200 trials that we could include, also a large group of studies with low risk of bias. We looked at response as a 50% symptom reduction between baseline and post-test. We looked at remission, defined as a Hamilton score lower than 7, which is the convention in the field. But we also looked at significantly reliable improvements and reliable deterioration. And we looked at absolute outcomes. So what happens within the treatment group and what happens within the control group. And here you see what we found. We found that psychotherapy, the response rate is 40%, 41%. So meaning, that 41% of people getting therapy have a 50% symptom reduction. This is a very conservative estimate, assuming that all people who dropped out of the study were non-responders. So this is maybe a little too conservative, but it still means that a lot of people who get therapy don't get better. And that's something, it's not related to that you didn't do the therapy well. It's not that does not mean that you have to go back to the diagnostic phase because this person, we thought this person had depression, but he doesn't respond to therapy, so it cannot be depression. That's not true. This is just the outcome that you get. And if you look at the control groups, there you see that in care as usual and waitlist, the response rates are 0.17 and 0.60. Remission rates are even lower. So 26% of people are really better. And you also have this small group of people who deteriorate. It's 1 in 20 who get worse when they get therapy. That's the good thing is that deterioration rate is lower than in a control group. So then when you don't get treatment, there are more people deteriorating. But it's still important to know that if you treat people, 1 in 20 will get worse when you give them treatment. So we did this not only for depression, but we did this for 8 other disorders that we had in our databases when we wrote this paper, which will be published in the June issue of World Psychiatry. And there we found the response rates, which was always defined as a 50% symptom reduction between baseline and post-test, which may not be correct for many disorders, like for panic and for social anxiety. Maybe that's not the best definition of response, but we wanted to have a response which is the same across all disorders. What you see here is that for anxiety disorders, OCD and PTSD, the response rates in treatment are between 30 and 40%, so also not really very high. And of course, for borderline, what you would expect, the response rate was even lower, while the treatments often, of course, are much longer. So the next thing we also examined is how can you deliver therapies? Can you do that individually or by digital means or in groups or by telephone? This is a meta-analysis we published a couple of years ago in JAMA Psychiatry. We focused only on cognitive behavioral therapy to make it less heterogeneous, so to say. And so what we did is we examined individual therapy, group therapy, guided self-help, telephone therapy, and unguided therapy. Guided self-help and unguided self-help were almost always digital. So in the guided self-help group, we had a few studies where people used books and weekly telephone support by a clinician, but almost all of them were digital. The unguided trials were all digital. So what did we find? Yeah, we basically found that there are no significant differences between the different formats as long as there's human involvement. So you can deliver CBT individually, by phone, in groups, in guided self-help, no significant difference between the effects of these therapies. In unguided self-help, the effects are somewhat smaller, and I will show you later that they are effective, but much less effective than the other formats. What is important here to realize is that if you do digital interventions, so guided self-help, then the dropout rates are higher. So that is something you have to keep in mind, but not the effects. So we also looked at our age groups, how are psychotherapies across age groups. We worked in this with the group of John Weiss, who have done a lot of meta-analysis in children and adolescents. This was a conventional meta-analysis in which we just looked what happens in these different groups. And so here you see the number of studies and the effect sizes across the different age groups. And what we saw is that when people are adults, it really doesn't matter. Then you do not find significant differences between these age groups. Even in old people, so these are studies in people with a mean age of 75 years and older, you find that psychological treatments are effective and not significantly different from the effects in other adult age groups. Psychotherapy is less effective in children and also less effective in adolescents. And that's a significant difference. So we examined also, I didn't show that, but we also examined what the response rates are in children and adolescents. We could only examine that in adolescents. And what we found is that the response rates within the therapy group are comparable to those in adults, so about 40%. But the response rates in the control groups in adolescents were higher than in adults, which in a sense, makes sense. Because in adolescence, things change more quickly. We also looked at all kinds of secondary outcomes. So what does, if you treat somebody for depression, what are the effects on other outcomes, secondary outcomes. So we examined quality of life, social functioning, anxiety, self-esteem, hopelessness, etc., etc. What we usually find is that psychotherapy for depression has also an effect on the secondary outcomes, but that's usually somewhat smaller than the effects on psychotherapy. We found here in the last meta-analysis, we found only 4 studies on the effects on suicidality. We have now a paper accepted in Lancet Psychiatry in which we included a larger set of studies. And there we found also that psychological treatment also has an effect on suicidality. There is a small group of studies in mothers with small children, and we looked at the outcomes on children, and we found a significant effect on the children, on the interaction between mother and child, and on parental functioning. Unfortunately, there are not many studies examining the effects of psychotherapy for people who have a depression plus a comorbid disorder. So these are trials in which only people are included when they have depression and anxiety, depression and insomnia, or depression and substance use problems. And as you can see here, we found a small but large enough sample of studies on anxiety, insomnia, and substance use. And what you find for anxiety and insomnia, you find that the effects on depression are good, comparable to what we find in people without these comorbid disorders. And you also find good effects on the comorbid condition. So when people have anxiety, you find good effects on depression, but also on anxiety. And the same for insomnia. If people have substance use problems, then the effects are much smaller. And the effects on substance use problems are also hardly significant. So when people have depression and a substance use problem, then treatment is often very hard. We found hardly any studies, for example, on depression and personality disorder, while clinically that's a very important problem. But there is just no research. So we have examined all kinds of other things. Therapies work just as well in student population, in people with comorbid general medical disorders, in postpartum depression. The effects are somewhat smaller in primary care. When people have chronic depression, as I said, when people have comorbid substance use problems, we're examining that more in detail now. When people have subthreshold depression, although they have less room for improvement, so it makes sense that the effects are smaller in subthreshold depression. But we do find a significant effect on the incidence of major depression when you treat people for subthreshold depression. Surprisingly, we found no association between the number of sessions and outcome. No association between the number of sessions, the contact time, how long the therapy lasted. We did not find an association. We are updating this now, this paper, and we find exactly the same thing. What we do find is that if you give 2 sessions per week, that the effects are larger. So there is an association between the effect size and the frequency of sessions. And we repeated that in a new randomized trial, and we could confirm that. We have also done a lot of work on comparing trials in high-income countries, low and middle-income countries, looking at the health regions of the WHO, the income of the country according to the World Bank, categorizing them in high, low, and middle-income countries. And what we basically find is that trials in in outside Europe, the US, and Australia, usually find a somewhat larger effect than in Europe, North America, and Australia, which is a bit strange because that's not where the therapies were developed. There are very few therapies developed in low and middle income countries. But still, the Western therapies do better in low and middle income countries. That can very well be an artifact. So I often say that therapies are at least as effective in low and middle income countries than they are in high income countries, and maybe even a little better. But that can also be related to, for example, care as usual, which in high income countries is something completely different than care as usual in India, for example. But anyway, what I do want to show you also is what I showed you until now is that we focus, that we do these conventional meta-analysis where we looked at the published studies, but we also have done individual patient data meta-analysis, and we're expanding that more and more and more. And that means that we try to get the primary data from these randomized trials and pool them together into one big data set, because single randomized trials they're powered to find an effect of the intervention. They're never powered to find who benefits from this intervention, so predictors and moderators. But if you pool all these trials into one big data set, you do have sufficient statistical power to see who benefits from an intervention. And this is work that is done by my valued colleague, Irini Kariotaki. She leads this work. And this is a very big IPD meta-analysis, about almost more than 9,000 people, almost 40 randomized controlled trials on digital interventions. And these could be guided or unguided. And what we did is an individual patient data network meta-analysis. So we had unguided, guided, and control conditions. And then if you go to this website, you can fill in at the left side of the screen, you can fill in the individual characteristics of a patient. So you can vary baseline severity, you can vary age, the gender, et cetera, et cetera. And then at the right side, you get what this individual patient, what the outcomes of guided, unguided interventions are for this specific patient. In general, we found that for mild depression, guided and unguided interventions are very comparable, no significant difference. But when severity goes up, then guided interventions are definitely better than unguided interventions. But both are better than control conditions. Okay, I see that I'm running out of time. I do need a few minutes to finish. I will try to do this more quickly. We do have a problem with the quality of these trials. So waiting list control groups overestimate the effects of treatments. Risk of bias, which is a rough, you could see that as an indicator of the quality of the trials. 80% of them has some risk of bias. Publication bias, which refers to the phenomenon that negative outcomes are not published, which interferes with meta-analysis because then you only see the published studies. Researchers are often inclined to try to make the outcomes more positive than they are in reality. And if you adjust for all these problems, we can do that. We have methods to do that statistically. Then you see that the effect sizes drop with 50% after adjustment for these problems. That's really something you have to keep in mind when you read a meta-analysis, that you really have to look at the quality of the included studies and if the meta-analytic researchers adjust for all these problems. Okay, very briefly, we did a network meta-analysis in which we compared psychotherapy, pharmacotherapy, and combined treatment. Large number of trials, 12,000 patients. We looked at response, and what we found is that psychotherapy and pharmacotherapy at the short term, they have comparable results. A combined treatment is better than either one alone, and that's also true at the longer term. And at the longer term, we found somewhat better outcomes for combined treatment and psychotherapy. And this also brings me to the next paper in which this was led by my colleague Toshi Furukawa, where we cut the treatments into two, an acute phase and a maintenance phase. And in the acute phase, people could get psychotherapy, pharmacotherapy, combined treatments, and they could switch to any of the other in the maintenance phase. And then you can look, we only included studies in which all people who were randomized were also included at the 1-year follow-up analysis. So 80 trials, 13,000 patients. This is the network plot, but this is the outcomes. And summarizing, psychotherapy is better than pharmacotherapy. Even one-time psychotherapy is better than taking antidepressants for a year. The combined treatment is better than either one alone. So the combined treatment, psychotherapy plus pharmacotherapy, is better than psychotherapy alone, better than continued psychotherapy, and certainly better than pharmacotherapy alone. This study, both these studies were also used in the updates of the MHGAP guidelines, which were published a couple of months ago. And they now recommend not to use antidepressants without psychotherapy, unless there are no trained clinicians. So I think that's an important message. I skipped this. We just did the same thing, the individual patient data network meta-analysis. We're preparing many more of these. So this is really a quickly developing part of our meta-analytic work in which we look at the relative effects of treatments and make personalized recommendations for patients. So very briefly, it's important to realize that treatments are evidence-based, but that doesn't mean that everybody gets better. If a patient doesn't respond, that doesn't mean that you didn't do the therapy right or that the diagnostics are wrong. This is just the optimal effect of therapies. And so we really have to think about sequential treatments. What do you do when people don't respond? And where do you start? Maybe you should start with behavioral activation because it's so simple or relatively simple, and then move to CBT. And if somebody doesn't respond, then you should switch to interpersonal. We haven't thought about these sequential treatments. Okay. I don't think we need new therapies, because all these therapies that have been developed, you can see that over the past 5 decades, that now and then you get all these new therapies, which are very promising, but in the end are never better than the therapies we have. So I think we should just accept that therapies are not effective in everyone and make rational decisions about sequential treatments, instead of hoping that this new therapy, which is so much promised by the developers who publish books and go to conferences and are enthusiastic sellers of their new therapy, that hasn't worked. So we need a new innovation scheme for the innovation of psychotherapies. I have a paper which I just wrote about that, so I hope that will be published soon. Okay, and then as the last thing, I want to just make a PR for the journal of which I am the editor now. If you do clinical psychological research and you want to submit your paper to a very good journal, you should submit to the Journal of Consulting and Clinical Psychology, of which I'm the editor now. And I want to thank you for your attention and for not falling asleep. I cannot see that. Maybe you did fall asleep, but I assume you didn't. Thank you.
Thank you very much, Pim, for your wonderful presentation. Really very, very interesting. I give the turn for Pamela that will present Ricardo.
Well, thank you, Pim, for your insightful presentation, through which we have seen the great advances in clinical psychology. Your work has not only enriched our knowledge, but also set the path for future endeavors in mental health treatment and research. Well, having had the honor to collaborate with Pim during my doctoral research at the Pontificia Universidad Católica and the Universidad de Chile, I can personally speak of his deep knowledge and strong dedication to advancing our understanding of mental health. We are profoundly grateful for your illuminating presentation today, which not only reflects your vast experience, but also your ongoing commitment to enhancing mental health outcomes globally. Now I'm very pleased to introduce Professor Ricardo Araya, another leading figure in global mental health. He is a professor of global mental health at the Health Service and Population Research Department at King's College London. And his groundbreaking work in developing and implementing accessible and effective interventions for mental disorders, especially in low resource settings, has transformed the delivery of mental health care in different regions. Award the Chilean National Applied Science Award in 2022, Professor Araya has dedicated his career to creating scalable and sustainable mental health solutions. Professor Araya has led innovative research initiatives that extend from Latin America to Africa and Asia. His development of a collaborative care model in Chile for the treatment of depression and anxiety, which has been successfully adapted and implemented in several middle and low-income countries, exemplifies his skill in translating research into practice. Looking forward to his thoughts on Pim's presentation, we expect to learn more that will deepen our understanding and approach to mental health care and research. Please go ahead, Ricardo.
As usual. Thank you so much, Pamela. It's a great pleasure to be with all of you and to share the platform with my old friend, Pim. I say my old friend, Pim, because I know Pim for, I don't know how many years, at least 2 decades. And I've had the opportunity of working with Pim in projects and preparing, writing papers on various things. And it's always a great pleasure. Pim is very humble. I don't think there is anyone who's done more meta-analysis in psychological interventions in the entire world. And he's one of the most accomplished researchers worldwide. So it's a little bit kind of like one has to be very careful when commenting on what Pim is saying, because he sits on so much evidence. But I guess, there are so many things that, one can comment. But perhaps, I would start with, and some of these things I would like to ask Pim, what he thinks. But one of the things is something that I've heard from so many other people. I often was amazed when the previous director of the National Institute of Mental Health, Tom Insel, will go around sort of, complaining that the treatment, our treatments for depression were so bad that nothing that we had developed was actually working. In particular, he was referring to medication, because medication in most of the more recent meta-analysis is like, sort of, you don't pass the 50% response rate with medication, which is almost like sort of flipping a coin, it's not really very exciting to hear that. And is that, we've spent trillions of dollars on this, and that, we haven't really made much progress. Currently, there aren't too many innovative treatments being tried out. So it seems like, medication line is rather stuck. On the other hand, Tim mentioned about the result with psychological therapy, which are, more or less similar to medication. He referred to that later during his talk. So we are with these sort of two options that, well, in the past, they were considered to be two options. And both of them, give you roughly about the same response rate, which, one would wish that it was better than that. And then, of course, as Tim mentioned, the combination of the two things seems to be the most potent thing. We know that from a very long time, actually. I remember reading a very small systematic review in the early 90s. I even remember the name of the author. It was someone called Cascalenda. And she came to the same conclusion, that combined treatment was far more effective than each one of the treatment given separately. So we're kind of sort of, now with more evidence, as Tim said, we are kind of coming to the same conclusion, which is something, a big piece of evidence that can help with, informing treatment decisions. There are so many, we have to realize, that Tim has chosen to spend the last 50 years in a field which is quite difficult. Research in psychological intervention is a complex field. It's not easy. There's so many variables, some which you can account for, many that you not account for. They go into a sort of kind of a black box. And it has been my case, and I wanted to ask Tim about this, Pim. In most of the things that I've been involved with, the trials that I've been involved, what we test is packages. And the packages within the psychological intervention is a package that includes so many different things. It has a little bit of behavioral activation. It has a little bit of problem-solving therapy. It may have a little bit more of assertive training, and you name it, a bit of IPT, a lot of it, a lot of different things. And it makes it quite difficult to kind of begin to unpack this and to be able to make a comment on which one of these things is actually more effective than the other. There are some that, give prominence to one in comparison to other, and maybe one can, get a little bit closer to the answer. But I always kind of sort of, feel a bit uncomfortable, with the idea that all psychological therapies, whatever the type, they're all equally effective, and with the evidence to support that. What do you think, Pim? Do you sometimes think about that? Is it a big problem? Can we do something?
Thank you, Ricardo. It's always nice to see you and to continue the discussions we have and to do collaborative things like this. That's always a pleasure. So thanks for your comments and for your question. Yeah, of course, everybody thinks about what are these active components. There are lots of groups all over the world. The major problem is that we can do randomized trials which show if a package or an intervention is effective. But that does not allow us to examine how that works. So we just don't know how therapies work. Alan Kasten wrote a very nice paper about that in 2007 already, in which he showed that all the evidence on components is correlational. Randomized trials are in fact an experiment, and they can show if that therapy works or not. But if you want to examine all these different components and mechanisms, that's something completely different. You can do dismantling studies. We have a few. But then if you do a dismantling study in which you examine a package with or without one component, then you always have to count with small differences. So you have to think about an effect size of 0.2. But if you want to do a randomized trial powered for an effect size of 0.2, you need 500-600 people. And we did a meta-analysis on dismantling studies. There was one trial with 300 or 400 people, but the other studies, the largest one had 100 people in the comparison, and that's basically meaningless. And if you want to examine one component, that requires a major research effort, and that's just not done. That's not done. Meaning that we simply don't know how therapies work. I wrote a paper about this in the annual review of clinical psychology in 2019 about the common factors, because that's another thing. We often think when we talk about CBT that we learn patients how to think differently or be more active or whatever. But it could also very well be common factors like the relationship or the alliance or giving people hope, etc., etc. And it probably is a combination of the two. But disentangling that within these packages, that's not feasible. You need a research program, 10 years, $3 million per year, to examine one therapy on how it may work. So that we have done 1,000 trials on therapies for depression, but we don't know any of them how they work.
Yeah, it's incredible you say that. It's a phrase to keep for the people listening.
No, but I
shows the complexity.
Yes, but I also think we should step out of this idea that everything is complex and that we don't know things, because in a way it's pretty simple. We have treatments that work in a lot of people, not in everybody, and we should continue to give people treatments until they're better. And what we do now is we do a trial, all these dozens of trials which are published every year. They focus on people with depression in general, but we don't know, there are hardly any trials on sequential treatments. If you start with this treatment, what do you do? And people don't respond. What do you do next? We have hardly trials on clinically relevant things like people with comorbid personality disorder. Any clinical psychologist you will talk to about this will say, well, yes, if you're in specialized care and you treat people with depression, most of them have personality problems. But we don't know how to handle that. We just don't know. So it's not so, the questions are pretty straightforward. And solution is also pretty straightforward. But we have to do it. We have to focus on helping people with depression instead of trying to write papers, trying to make new.
Well, that takes me to the next point. because, well, you gave us a few snippets of, a few numbers that they were a bit depressing to hear. At the beginning, when you were talking about the burden of depression, you said that only 33% reduction with all treatment, which it kind of like made me believe, which is, I think, it probably right. There are many other things that are causing depression that we don't even consider when we are treating people, like sort of social problems and this and that, perhaps, if you were to introduce elements to ameliorate some of the problems, you may get better results. But that it takes me into the social determinants of mental health. But I don't want to get into that. I want to take you to task with the last thing you said, which is to do with the implementation. Because I mean, you say, okay, let's take the positive side of the story, and you say, well, there is treatment, and psychological treatment can work. But the reality is that in most of the low-income countries, which actually represent almost 90% of the world population, there is virtually nothing, very little, including countries which are kind of aspiring to be rich, like Chile, for instance. There is very little in terms of, delivering psychological therapies for the population at large. There are a few things that, if you look at the guidelines that they have for the treatment, which is sponsored by the state, it's called HES. In the package, there is an element that people should receive something like this, but it's not very clear what exactly people should receive. It hasn't been standardized, or there aren't really very clear guidelines to what you should be giving. And in fact, nobody's actually checking. And when you don't monitor what you're asking people to do, most likely that people don't do it. So implementation in mental health is a major issue. It seems to be a major issue. And when you do things at a larger scale, you begin to depart from the fixed condition that you encounter in a trial. And often the effect sizes that you get in a trial, you have to dilute that substantially for what you're going to get when you implement things. So I wanted to ask you, what do you think about this issue about implementation, Pim, and what's the way forward with this?
Yeah, again, I think that's a very good point. In this talk, I talked about treatments and how you can improve them. But of course, as I said in the beginning, implementation is at least as important as improving treatments. I've done a lot of research on digital intervention, so maybe I'm a bit biased. But I think you can also approach this pretty rationally. It all depends on the resources that a community has. So if a community has hardly any resources, and if poverty and famine is more urgent, then you don't spend things on mental health problems. That's obvious. But if a community has a little money, what you could do is develop unguided interventions, digitally or in books. That doesn't matter. Of course, you don't reach everybody. Of course, that's only for a part of the people who have internet or who can read or who have access to books, etc. But you shouldn't you shouldn't forget what I said in the beginning. If you have an intervention like unguided self-help, which has effects, which is better than doing nothing, and you do that in communities, in large communities, then even a small uptake with a small effect can have a huge impact on mental health. So if you have an unguided intervention and you manage to disseminate that in China, in Mandarin, or you can make it in Spanish, where you can develop it across all Spanish-speaking countries, then it's still only a fraction that you do, but you can do that. It hardly costs anything. You need to develop these interventions, translate them, adapt to the culture. That's the first step. Then if the community gets more money, you can do guided digital interventions or guided self-help with books and telephone support. We're doing this in Lebanon now, where we developed a smartphone app based on the WHO PM Plus intervention. It's called the step-by-step intervention.
Guided by who, Pim?
Sorry?
Who would be guiding in your view?
So in Lebanon, we trained lay counselors to help people work through the digital intervention. So and that's still very cheap, because if you work with trained lay health counselors to deliver guided self-help, I mean, you can help one patient in 1 to 1.5 hours. And so if you have more money, if you have very little money, you develop unguided interventions. If you have a little more money, you develop guided interventions. And if you then have more resources available in the community, you can, in addition to that, start training nurses or other lay health counselors in primary care centers. And if you then approach a high-income country, you could think of developing a specialized mental health care. So I think it's all, now nothing happens in the majority of communities. And I think that's not just, you can do a lot even with low resources. That doesn't mean that you can help 80% of the world, of the 800 million people across the world with mental health problems.
Yeah, no.
But you build it up, so to say.
I don't think we disagree on this, Pim. I mean, as you know, I'm one of the champions on the idea of task shifting to other people. Well, I found, do I have 2 more minutes, Marcia? I don't want to take it.
We have a couple of minutes, and then maybe Pamela will present the question of the public.
Okay, let me just make a comment which is relevant to Chile then. Because when I was there last time, I mean, I've been promoting the same idea as Pim, you do as much as you can with the resources that you have available. And then you have the resources and you think, what's the best I can do with those resources? What is the most cost-effective intervention with that level of resources? And then you come to this thing that you're not going to be able to provide, psychotherapy, fully trained psychotherapy with a master's degree to the entire population of Chile. So I will come sort of promoting the idea of task shifting, of training people, to become mini counselors or different kind of thing. But I could hear among my Chilean colleagues and the audiences that I was speaking to, a bit of resistance, and even among some patients, I have to say, that I spoke to, that they felt that, I was trying to sell a low quality kind of treatment, that they should be treated by a psychologist. What on earth, what is it the guy is trying to propose? That they're going to train, mini counselors and they're going to come and help? No way. And I kind of said to people, well, if that is your idea, you may be waiting for a long time, because I mean, even though I think Chile is in a position, money-wise, to offer something better, things are not moving, because there is a resistance because of this idea that, either you offer the perfect recipe or there is nothing else. So I think I wanted to say that to provoke the audience, and to jump from my neck because they can't get it because I'm far away, so they can't kill me now. But I think it goes with what Pim is saying, you know, it's not just me saying it. A lot of people are saying the same thing. And
Yeah,
that,
I can add to that we're doing now a network meta-analysis on the different therapies, therapy formats in low and middle income countries. And we don't find a difference between lay health delivered therapies and face-to-face therapies by clinicians. But I mean, it's also it's also patient preference. Some people want to talk about their problems to somebody who listens to them, but then they cannot get a structured psychotherapy which has been shown to be effective. And I understand that people want to talk, and there's nothing wrong with that, but that's not something you can deliver if you think about reducing the disease burden of depression on a national level, so to say. It's not something you can provide when people want that. Yeah, that's good. And if you find somebody to talk to, you should do it, but that's not. So I fully understand it, but it's, yeah, you cannot spend your money twice.
I can never forget the conversation I had with a Dutch friend of yours. I'm not going to give the name about this thing, because I was saying to him, you know, that this delusional idea that comes from Western countries about choice. There was a time where choice was a mantra that, you know, and I try to explain to these people that in some countries you have more choice than others. And there are some countries where choice doesn't exist. So you offer people what is possible, and there may not be much choice. And people have to either take it or there is nothing else left. So it's, you know, it's like, you know, it's wonderful to have choice. But, you know, choices is something that it's related to the resources that you have available to deliver something. It's not always possible to have all the choices in the world.
Exactly. But now I want to know the name of the guy, of course.
No, I won't tell you the name because you know him. It's Dutch. I'll leave it there.
Okay.
Sorry, Marcia.
Yeah.
Okay.
Okay. Ahora, now Pamela will present the question of the public.
Yes. Well, at first, I want to say that we have received numerous comments from the audience expressing gratitude for the talk and praising its excellence. We have a lot of comments saying that they are very happy with the talk, and they have wrote a couple of questions. I would like to note that the questions were collected throughout the presentations, so it is possible that some of the questions may have been addressed in later parts of the talk. We have one from Maria Isabel Gaete. Evidence-based treatment are mostly available for high-income people and high-income countries. The evidence itself is taken mostly from high-income countries' populations. So, do you think that evidence-based treatments could fit worldwide? What do you recommend to fulfill this gap from research?
Yeah, I think I talked about this in my presentation. We did a few large meta-analysis, which we compared psychotherapies in high-income countries to therapies delivered in low and middle-income countries. And we found that therapies are more effective in low and middle-income countries. And maybe an artifact, but they are certainly as effective as in high-income countries. As the evidence is pretty strong in that respect.
May I say something else about that? I think, you know, some of that is to do with the starting point or the ceiling effect, if you want to call it, or the floor effect. I mean, because, you know, when we did our first trials in Chile, treatment as usual was so poor. Almost as poor as the one you show us today, Pim. But, you know, it's like sort of, you know, 15% in the first trial that we published in Lancet in primary care, 15% of the women were recovered at 6 in the clinical, in the usual care group. And now when we do trials now in Chile, we get about 40% recovering with care as usual. So the difference between the intervention and the control group has become much narrower these days. So it's becoming more difficult to bring in new interventions that they're going to make the difference.
Thank
Yeah,
you, Pim.
wonderful that you managed to get that care as usual response rate so much up. That's amazing. Well done. Congratulations.
We have another question from Victor Macias. I think it's more of a comment. I think it is more important to emphasize that they come from places where science is done. What is important is the progress of science to make discoveries in health improvement available to all. I think it's more comment. I don't know if you want to comment on this.
I mean, it's important to get all the knowledge out. And what we do with our MetaSci project is we try to get all the evidence together and make it available to everyone. I don't consider it our project. This is the cumulative knowledge that we as a field have collected, and we just make that available. And I fully agree that all this knowledge should be available for free to everyone in the world.
Yeah, I mean, democratizing science is a massive challenge. But may I just say to Macias that, you know, we do have some evidence in Chile, and I found it really discouraging and sad that very often people don't even know, you know, the kind of thing that we've done and the evidence that we have about certain things that work. Not even to mention that most of these things have not been implemented. So partly it's because we don't have the science, but also because we have the science, but somehow it's not taken into account.
Thank you. We have another question from Sebastian Perry. He asked, do these results include psychotherapy combined with psychiatry treatment? I think you addressed him this question with the study about combined treatment.
Yeah, so we specifically looked at psychotherapy versus pharmacotherapy and combined treatment. But we also did a paper last year in European Psychiatry in which we examined if the proportion of people using antidepressants had an effect on the outcomes of psychotherapy, and it had not. So it could be possible that if people take antidepressants and they get psychotherapy, that then the effects of the psychotherapy would be a little smaller. But that's not what we find. So the relation with pharmacotherapy is pretty well examined, and it's as I summarized in my talk.
Thank you. And we have only 2 more questions from the same person, from Maria Isabel Gaete. I'm going to read both. CBT is for far one of the better shaped manualized psychotherapies. Do you think that its supremacy on the available evidence has to do with that? And the other question is, maybe the pathway for answering how psychotherapy works goes towards qualitative research more than RCTs?
Oh, these are 2 very different questions. CBT is it was developed in the 1970s, and when you have CBT with a manual, it's replicable, so many people can do the same manual, which makes it more easier to examine in randomized trials. That's definitely true. But I mean, if you look at interpersonal psychotherapy, behavioral activation, and now also brief psychodynamic therapies, they're also all manualized. Only they don't have the research I mean, for many people, CBT is a synonym of psychotherapy for depression because it's so dominant. I do think that CBT, I mean, it's the best therapy we have. We know not the best therapy, but the best examined therapy. But we also know how it works compared to pharmacotherapy at the long term in this population, in that population. So it's in many ways, it is the gold standard. That doesn't mean it's more effective. And that doesn't mean that I'm happy that it's becoming more and more dominant. But it is the gold standard, so to say. And it's very difficult to improve it. All the attempts to improve it have failed.
But it is a very good point. It's a very good point, Pim. Would you agree with that? That, you know, certain things that lend themselves to be standardized, they have a better chance to be researched than other things that are more, you know, difficult to put into a manual, so they will have an advantage.
Absolutely. I mean, you need. I mean, replicability is a requirement for doing a good randomized trial. If you don't have a manual and you tell people roughly what to do, then you don't know whether the outcomes are related to. And you don't find outcomes, maybe that's related to the fact that all these people do different things. Well, in a manual, that's all standardized and structured. And then you know that if you have a structured treatment according to that manual, if that works, then you know that's what you have to do in practice. And if you don't have a manual, then yeah, that's, I mean, nowadays all trials have manuals. In the older days, people said, well, we're going to do Rogerian therapy. And then they didn't have a manual, but that's not happening now.
And it's an interesting point because there are many people, probably many people listening to you today, that they're practicing clinicians, and they take a more eclectical view of how to treat people. So they're open to, because they have good training and many different approaches. So they take, you know, sometimes they do a little bit of, you know, cognitive, you know, challenging thoughts and restructuring. Sometimes they do a little bit of, you know, behavioral activation. Sometimes, you know, they use different, you know, they have a toolbox that incorporates so many different things. And that is, you know, takes me also to the point that I was making to you before, that, you know, how difficult it is to disentangle things. Because even if you think about, like, for instance, you know, think about behavioral activation. Nothing can be packaged easier than behavioral activation. But it's not that simple, and there are different approaches to behavioral activation. If you take the modified behavioral activation of Sonia Dimijan and Chris Martel, it does have a lot of cognitive restructuring within the package.
Yeah.
But if you take the old, you know, kind of thing, it does have a lot of problem solving in there, you know, this real, the initial kind of stuff, you know. So it's just, that's where the complexity, I see the complexity, and it makes it more difficult.
Yeah, but we did a meta-analysis in which we separated subtypes of therapies, and we found two subtypes of behavioral activation that were examined in enough trials. So the new Chris Martel approach to behavioral activation, and the old approach from Pete Lewinson from the 1970s, and you don't find a difference. There is no difference. So I don't think that kind of thing really makes a difference in terms of outcomes. And in terms of, I do like that as a therapist you're eclectic, but I think you should, doing a packaged manualized therapy, you don't need therapy training of 20 years to do that. You can ask young psychologists to do that. But when people don't respond and things are more complicated, then you need more specialized people, because then you don't know what to do. And then the only thing you can do is an eclectic approach. So I would really separate the two from each other. But anyway, we're over time. I didn't answer the question on qualitative research. I really think qualitative research is an essential part of the further development of research. And if you look into what happens in individuals in therapy, you can discover how people experience that and maybe find new ways to treat them. Very important.
In fact, if you think about randomized controlled trials in general, for anything from cancer to depression, most of them these days have a qualitative arm to try to understand what's going on,
Exactly.
at a minimum. Back to you, Pamela.
We are in
Marcia,
yeah. We are in the final part. Thank you very much. It was very, very interesting. A lot of ideas for MIDAP researcher and the clinician from Chile and maybe of the other countries. It was really, really interesting, and it's very impressive. Your Pim, a lot of idea and question about parenting and child, but for other occasion. Thank you very much, Ricardo, for pointing the Chilean reality in your reflection and the differences between research in Europe or United States and Latin America. It's very interesting. This is the end. Goodbye and thank you very much. Pamela, want to say something too?
well, I also want to thank you both. I think your reflections have been very enriching and valuable for all of us and for both clinicians and researchers. So I'm deeply grateful for having you both here. Thank you very much. Thank you to the audience also, everyone who is out there watching this talk.
Perfect. Thank you.
Thank you. Lovely to see you, Pim.
Goodbye. Have a
Bye.
good day.